Dear ladies and gentlemen, I thank the organizers to be able to give a speech at this very interesting event, and thank you to the Armed Forces of Ukraine for this opportunity to enjoy this event. As many other hospitals in Ukraine, after the beginning of the fully fledged invasion, we came across new problems, new challenges. And one of the problems was dealing with neuropathic and phantom pain in servicemen after they got wounded. So more and more defenders, they lose their limbs, and the trauma of extremity is one of the prevailing ones in this structure of combat trauma nowadays. And certainly we don't have the official data, but preliminary the assessment is more than 100,000 people lost at least one of the limbs in Ukraine. So how can we compare it with something? In three military campaigns in the United States, two Iraq and one Afghani campaigns, they had 1,700 defender fighters with amputations of limbs. So you can see in Ukraine this problem is so much bigger and so much deeper. So what is pain? What is phantom pain? There are a lot of definitions of pain, and there are many approaches to defining it. The most old type of kind of definition I found in a dictionary. It says that there is an emotional component of pain syndrome, and the modern definition uh, of the International Association for the Study of Pain, what is stress? Pain is it's more than sensation, it's more extensive. And pain has also emotional coloring, and it's also related to one's experience, and it's always subjective. Whatever your patient calls pain, you have to treat it as a issue. Neuropathic pain is when your nervous system was damaged, and phantom pain is one of the components of the neuropathic pain. But still, it's being discussed, this issue. When we talk about the phantom pain in the limb of a wounded person who lost their limb, we should talk about three different things. First, phantom sensation that all patients have after they lose their limb. Then, a stump pain. It's a kind of pain with any characteristics in the residual limb. So the phantom pain is the pain only in that part of the limb which is absent now. So talking about studying pain and approaches in treating the pain, we are now looking at the, the concept. When talking about phantom pain, we need to understand that there are many various components and levels of this pain in the neural system. It's not only about the limb where it forms. It can be spinal cord and thalamus and cortex of the brain. So there are certain confirmations to that. So peripheral component. The research of the Black was published in 2008. So the expression uh, growing of NA channels expression in damaged nerve, it testifies to the fact that a tiny irritation would increase the pulsation in your nervous system. So other levels, we're talking about the cortex of the brain, homunculus, maybe notion. I think the students know what this is. Well, in 2001, Fleur published for the first functional MRI results, and there was a sharp increase of excitation areas in patients with phantom limb pain. And in normal patients, this excitation was absent. and in patients who didn't have phantom pain also didn't have it. So there is a lot of clinical research that testifies to about many levels of neurological system involved in phantom pain. So the main targets that are being studied, it's gray matter around the middle part of the brain, and also rostroventral nodes in the long brain. So they get impulsations from other parts of nervous system. So premotor cortex and gyrus cingulus. The neurologist experts, you know that these are the parts of neural system that they play role in forming your emotions. So diagnosing phantom pain. We always distinguish between acute and chronic, neuropathic or nociceptive, local or diffusal. So we are also trying to define all possible triggers of this phantom point. Sometimes it's just neurons. S- So neuroma triggers, the anesthesiologists usually deal with this. And when they find these triggers, they can do minimally invasive interventions on the nerves. So when medication uh, treatment is not effective, then we switch to surgical opportunities. And in our arsenal in surgery that we can use in these pain syndromes, we can classify them in two large groups: neurodestructive and neuroaugmentive, neurostimulating. So neurostimulating ones, they have three big advantages: safety, being uh, you can turn them back, and they also can be regulated. So if you put electrodes for various areas of neural system, you can always remove the electrode. But if you do the destruction of this neural system, you don't have that opportunity. So minimally invasive interventions also, they have ultrasound control on periphery areas of neural system, and the spectrum is very wide, and they are very effective usually. So it's one of the cases when anesthesiologist, they basically take away the job of a neurosurgeon. So periphery part of the neural system is always accessible. This is where the phantom pain starts. So usually it starts with neuroma surgery and preventing this primary or secondary arousal. So in the aspect, we are talking about symptomatic neuromas only, not the asymptomatic ones, because all patients have them after neural damage or amputation of the limbs. So there is a large spectrum of interventions, and there are various approaches that were defined. Bagdasaryan systematized them very well in his review. First of all, we use physiological methods of changing in the target of the nerve. So what we use mainly is RPNI, basically a small area of devascularized, deneuralized muscle tissue, and we form like a case for damaged nerve after we cut off the neuroma. So this we use this theory from the prosthetics. It's one of the basic approaches to reforming targets for bionic prosthetic limbs. The more targets we have, the uh, so the better it is. There is a chance for max to put on the bionic prosthesis maximum efficiency. So neurodestructive interventions, we usually use them with amputations. It's a dresotomy we use, but it's the most effective in patients who lost a limb, who had avulsion of spinal cord. What else we are using in Ukraine? In Ukraine, we have very little experience of epidural stimulants of spinal cord. We have even a Ukrainian device. It's not very good, but still. So the concept was proposed in 1967 by American surgeon. It's electronic put on dorsal part of the spinal cord to modify electrical fields. So if today we don't have any precise understanding how exactly it works, what we have is a tonic or traditional stimulation. We can stimulate with separate impulses, and also high frequency or like blast stimulation. It's not related to paresthesia, so the patients take it better, and it allows us to cover big areas of painful sensations. And there is no theory why, but there is a real awareness of the fact that it's effective. It does work. So from epidural stimulants, phantom pain is one of the main ones, although it's quite rare. Let's look at the stats of the three American campaigns. 1,700 people with amputations. Stimulating the spinal cord, it proved to be safe and effective. So the biggest complications were related to the equipment. So the electrodes move and the stimulator stops outputting the impulses that we need. So when we start working with the phantom pain in our hospital, we created one very short protocol of managing pain, which it got developed over time, and you can use this QR code to get to know it. Now it's grown. Now we start the treatment with pharmacological functional treatment of pain. If there is no effect, then it's minimally invasive injection procedures for peripheral nerves. If it still doesn't work, then surgical interventions on pain syndrome. So what we always stress is that we try to maximally remove the opiates from these processes. So everybody who comes across patients of Nobuffin complications is really widely spread. So it's something to pay attention to, and it's effective step in managing the pain syndrome. So what we talked already, and what I also want to support categorically, is the peculiarities of damages that we come across. It's multi-level, it's various parts of body, also the tips of the spinal cord and brain, and combined damages of ischemic, thermal, and also the emotional condition of the patients. All of them have this or that level of PTSD. Uh, Unfortunately, we have very little time, so our experience in pain syndrome is 5,000 combat injury, combat trauma patients. More than half of them are amputees. More than 1,000, they have a severe case of pain syndrome. And around 18 only, they had surgical interventions on pain, on phantom limb pain. So 19 patients neuromas interventions, and one patient, it wasn't effective for him, so we will mention him. So the first case, the defender who got wounded in 2022, he was held captive. Then on the battlefield, he lost one limb and then another limb. So no upper limbs and difficult pain syndrome, and he got his prosthetics in Hopkins Clinic. Then another case, a very interesting complication, like his uh, there was a hemorrhage of the nerve, and it was one of the components that that complicated this phantom pain. In 2 weeks after the surgery, the phantom pain was gone. And one more case, a very difficult case in long-term management of the limb. It's a case when sometimes we think maybe it's better to amputate on time. So it was so the pain syndrome in the limbs, whatever intervention there was, it was not effective. It was the first case for epidural stimulator that we used. Very low the electrodes were. Uh, so temporary electrodes migrated to epidural area, and then we installed the constant stimulator, so it helped a lot. The result was great. So there are a lot of prospects in treating the servicemen, but the the more losses Russians sustain, the better it is for Ukrainian. Phantom pain is a very difficult neuropathic neurological syndrome that we see in defenders, and it needs special attention, and it needs teamwork on many levels. So what I always say when I talk about combat trauma in our experience, please, the everywhere you can be so as much as aggressive as possible in managing the pain syndrome of defenders. It helps them with the treatment, it helps the morale and the optimism and the quality of life, and document everything you see. Whatever you come across in the injuries, please document it. As many a severe trauma as in Ukraine, you will never see anywhere in the world. It's a really valuable material that should be worked upon. You can't cancel out the wounds and injuries and trauma, and there is we can't stop the suffering, but we can minimize the suffering for other defenders. We always talk about the teamwork here. I'm not the only professional here. So as you see, we have 1,000 defenders and only 18 were operated on. So the team is so important. So now I'm talking about other teams who are defending us, and I would like to thank them. Thank you, Roman Iliuk.